here. We know that Zivia IVF, along with this Akanksha Hospital and Akanksha IVF, we have started this center in Jaipur, which is running very successfully. And as Mr. Sukhman said, we are going to increase the number of centers very soon. Today's topic is FSH and LH deficiency, which is very, very important in our IVF protocol, because the main thing to get good quality oocytes, we know that both these hormones are necessary. And we know that the gonadal failure is associated with reduced gametogenesis, reduced steroid production. It may be because these hormones are deficient or their action is not proper. Let us look at the natural cycle. There is follicular phase, then there is ovulation, and then there is luteal phase. Estradiol starts rising under the influence of FSH in the proliferative phase. With a negative feedback, FSH goes down. Positive feedback, LH comes up, and the progesterone secretion also starts. So the oocytes are basically first oogonia, from which the primordial, primary, secondary, tertiary, and ultimately the pre-ovulatory follicle comes up. And if we look at the competency of the oocyte, an early entrant is no good. With the FSH growth, there is a slow or low competence. Then comes the LH effect dominance in the later part, and finally that LH surge will make it a competent oocyte. So what is the role of FSH? The FSH receptors are on the granular cells, and granulosa cells, it will start the proliferation, antral follicle development and selection of a dominant follicle, estrogen production by the aromatase enzyme activation, and that will induce the LH receptors on the granulosa cells. And these, with the LH effect on these LH receptors, there will be oocyte meiotic maturation, and finally the disruption of oocyte complex trigger, and the ovulation will happen with sustainment of the corpus luteum. But we should also remember that there are LH receptors on the theca cells, which will help the androgen get converted to the estradiol when it seeps into the granulosa cell. So initial theca cells LH will help the granulosa cell androgen to estradiol conversion, increasing its sensitivity to FSH, increasing the substrate and giving those few extra oocytes. The deficiency of either or both these hormones can be congenital, acquired, or functional. Congenital is, we know, the hypogonadotropic hypogonadism. Acquired, congenital could also be because of the LH-FSH gonadotrophic polymorphism or the receptor polymorphism. Iatrogenic when we give a good amount of analogs or certain drugs. And functional is eating disorders, over-exercise, then impaired Gnrh pulses, or there could be radiotherapy, chemotherapy. Advanced maternal age, again you see LH and FSH deficiency, and that is transient, and that could be because of the reduced action or because of the genetic factors. Now, whenever there is reduced gonadotropin production, so there will be reduced impulses and this deficiency, or the gonadotropin may be normal, but the receptor activity is not there. You will get arrested follicular development or suboptimal follicular development, or there is a plateauing or decrease of estradiol. So these LH and FSH deficient women will be either poor responders or suboptimal responder, making this low prognosis patient group. The Bologna criteria, we know that maternal age more than 40, along with another risk factor like Turner or chemotherapy history, or a previous episode of less than 3 oocytes, or the markers are low like AFC less than 5 to 7 and AMH 0.5 to 1.1. Any two out of this would make the poor responder. And this had some pitfalls, and hence came the Poseidon criteria, which are very important to identify the poor ovarian response, which has converted to a low prognosis concept. Our main thing is whatever is the result, we want a good outcome. We do not want a poor prognosis outcome. So they have divided this into 4 groups. Group 1 and Group 2 have absolutely fine biomarkers with normal AHC and AMH. But group A is less than 35. You start stimulating, you get either just 4 oocytes or 4 to 9. And in group 2 also, the age is more than 35, but the response is 4 or 4 to 9 oocytes. Group 3 and 4 are definitely poor responder because their biomarkers are low for the ovarian reserve. Group 3 is less than 35 and group 4 is more than 35. The new concept that has come is follicle output rate. You see these antral follicles in the beginning and you expect, okay, I've seen 20, I'll get 18 pre-ovulatory follicles. Instead, you just end up getting 1, 2, 3. That means 20% or less hyporesponder, 70% is a normoresponder. And this can be noted in 15% of females where you were expecting a good response. And the FOI, low follicle to oocyte index. The first basal antral count is very good, 20, and you expect, okay, I'll get at least 15, 16 eggs, but you end up with 4. That means less than 50% low FOI. But if there were just 4 antral and you get 2 to 3, it's good enough because the FOI, that is follicle to oocyte index, is good. So now, how do we define suboptimal response? When it is 4 to 9, and hyporesponse is when it is unexpectedly. So even women who consume more than 2,500 of FSH or LH and still gives low follicles output is considered as a suboptimal responder. And low FOI is definitely a suboptimal responder. In 10 to 15% of women who seek AHRI with good prognosis, regardless of their age, you will end up getting this. And in the Poseidon criteria, they found out that 47% of patients attending AHRI clinic fit into 1, 2, 3, 4 Poseidon group. And of these, the 5 and the 35% belong to 1 and 2. That means their biomarkers were normal. Still 40% of these 47% responded poorly. And the HFEA data has showed that out of 400,000 cycle, 175 representing 43.3% were stimulated and retrieved oocytes for 4 to 9. But this is a good sign. In the first cycle, if you see this where you were expecting more eggs and you have not got it, there is a possibility to change the stimulation protocol and convert them to a good responder. And that is what we have to learn today, that how your first surprisingly hyporesponse can be converted or optimized to a proper response, which increases the chance of pregnancy. Now, if you get a low follicle to oocyte index, that means either you had started with a low dose, you have just started with FSH where you also needed LH, or there was some technical issues, temperature not maintained, or the triggering was not proper, or the time from triggering to retrieval was not proper, or there was genuinely an asynchronous growth, which you could not identify on day 1, or genetic or environmental factors. Genetic is the FSH receptor variant, mainly the serine 380 and the LH beta variant, serine 680, sorry. So these genetic polymorphism of the gonadotropin or the receptor will reduce the response and give a surprisingly low outcome. When they found out the hyporesponder patients, they studied their receptor polymorphism, they saw that almost 80% in the hyporesponse group had this compared to 20% in the normal group. Iatrogenic can be when you have used aggressively the antagonist or a long agonist protocol further with an advanced age patient, or where you had not diagnosed any genetic variant. We don't do that test routinely. Or the treatment itself was, you had faltered in giving the right dosage. So how to get a certain good oocyte in? Does one more oocyte matter? Yes, definitely one more oocyte matters and can help in give a 25% live birth rate more if you target for that 1 or 2 more good oocytes. If we look at the number of eggs that you need to give a positive outcome, when you get more than 15, you know 60%, but when you get just 1 to 3, it's going to drop to 20%. And to that you add the age variable, which is 1 to 3 times. 1 to 3 times 20% is 100%. 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 1 to where because of the age, mitochondrial function, granulosa cell are all abnormal, oxidative stress is there, and aneuploidy rate is high. So for 40 plus, you at least need 18 COCs to give 14 M2, and for less than 35, you definitely need 5 good M2. If we classify the low prognosis, let us look at the group 1 and group 2, which are the unexpected poor responders. How will you manage them? First cycle, you will not expect. So after only first cycle, this Poseidon 1 and 2 come into picture. So there is something you can do for pre-treatment, stimulation, and triggering. So in the pre-treatment, what will you do? Now the ART calculators are available. You can also think of genotype screening if it is available, because that will say that this patient will respond to higher dose of FSH, or you need to add LH, or even selected patients you can do androgen therapy. The variants that are the FSH and LH SNP screening is costly, so we don't do in the first cycle, but in such cases, even to counsel the patient why this has happened, it would be important. The treatment protocol will be, I would say, increase the dosage or better add LH. So if a young patient, you can think of second cycle doing 300 or considering LH in the ratio of FSH to LH 2:1. And more than 35 years of age, you can also consider doing duostep. And if you are adding LH in this group, you can consider adding 150. The Poseidon group 1 and 2, the triggering protocol, if supposing the group 1 young patient is showing more than 16 follicles, you can restrict to Gnrh, Agonist trigger, not to go for ovarian hyperstimulation. And for advanced age more than 35, also think of pre-implantation genetic testing for aneuploidy and consider single blastocyst transfer. LH is beneficial in terms of both oocyte quantity and quality in hyporesponders to FSH monotherapy. And in low FOD patient, sometimes to rescue the cycle, also in the middle of the cycle from day 6 to 8, you start adding LH, so that, because we know that by the time the follicle is 10 millimeter, 12 millimeter, actually there are more LH receptors than FSH. So just increasing the FSH dosage will go down the drain. It's better you add LH so that more and more LH receptors are occupied. In women more than 35 years age, again the androgen production is reduced, and hence the FSH receptor induction in granulosa cell by adding LH will become more responsive, and it can be effective in increasing the oocyte and embryo quantity and competence. This study shows that on day 7, if you see there is a slow growth, there is plateauing of the follicle. What follicles you were expecting to reach 15, 16 has stopped at 12, 13 only. Add LH rather than FSH, and they have shown that adding LH had a better and higher ongoing pregnancy days compared to adding just FSH. And another group where they found out that adding LH was giving a higher pregnancy than it is comparable to a control group as just adding the FSH. So overall incidence has shown that more than 35 years of age, I prefer REC LH, but any LH can be added. REC LH is more, you can use it in 75 to 150 IU. Now, this is the PERSIST study, where the study has showed that administering REC FSH and REC LH in the ratio of 2:1, 300 to 150, improved several parameters in patient undergoing the stimulation. And they've shown that adding from day 1 or day 6, they found that adding from day 1 had better chances than day 6. Now 3 and 4, these are definitely the poor responders. And here, the Poseidon 3, they say that adding LH always in the first cycle, like we don't do in Poseidon 1 also, is not necessary, because the endogenous LH is potent enough and you need just 1.2 of LH receptors to be occupied to give a good controlled ovarian stimulation outcome. So that they have said that there is 100% not necessary, but if one cycle fails, you can think of doing an LH in the second cycle. And Poseidon 4, at least add LH in the dosage of 2:1 FSH LH and a higher dosage. Now, poor responder, there are various protocols, and what protocol we follow nowadays is duostate, especially in patients who are really advanced. Age is a criteria, who have traveled from abroad, and we have seen that giving the second luteal phase, if you see that on the day of retrieval, there are some lead follicles which you expect, don't touch those lagging behind 10, 11, 12 follicles. 4 days later, you start the stimulation and you can end up getting more number of follicles, more blastocysts and more euploid embryos, but you have to select the patient properly. So you can start with 300 plus 150 is what we decide, or 225 also with 75 HMG. Give the antagonist from the day 6, 5, depending on the size of the follicle. Just give the agonist trigger, retrieve the eggs in 34 hours. 4 days later, start the second stimulation. The second stimulation can run a little longer, but the number of eggs you get is better. And you have to select, supposing that patient had 2 basal enteral, both you have retrieved. On the day of retrieval, you don't see anything lagging. Then you can counsel that we will start for 5 days, but if we don't see any coming up follicle, we may also cancel it. Now, the agonist microflare protocol was what we followed before. Give 15 days of birth control pill. Then, after the last pill, on the next day, you start microdose, 0.5 unit, 5 unit, 5 units. So 0.1 IU of the agonist in the morning and the evening. Once after 4 days, she gets a periods. Continue this microdose 0.1, that is 5 unit in the tuberculin syringe of the leuprolide in the morning and evening, along with the antagonist till the day of NCG. These are the patients where the AMH level you are looking at 0.8, 0.9, 1. You don't want to give that long to suppress the ovary too much. You can use this microdose protocol and with very good outcome. So this is to decrease the suppressive effect of that long agonist protocol, but only 15 days of pre-treatment with OC pills. Natural cycle mild stimulation cancellations are high, though with clomiphene we are doing a lot of stimulations. We have to explain the patients about the quality of oocyte cancelling of cycle, but it is economical and in a select group of patients. What we have started is clomiphene 100 from day 2. Day 7, you start the HMG, add the antagonist. We also add this antagonist from day 6 or 7, and then give the trigger of decapeptyl and retrieve because we avoid a transfer in the same cycle. That is one another protocol. Benefits are friendly, low dosage required, and cost is also reduced. Gnrh IVF, we use it in a big way, but at least 60 to 70 days, because what I showed from primordial to pre-enteral, it is going to take that time. Give that testosterone gel application daily. The pumps are quite convenient. Daily, the pump dosage should be given. And in the previous cycle, where you are going to start the stimulation from day 21 or day 25, depending on the patient's cycle length, you add estradiol, valeric 2 milligram in the morning, 2 milligram in the evening, and add prednisolone 10 milligram in the morning, 10 milligram in the evening, till the day you start the stimulation, that is day 1 of cycle, when the androgen should be stopped, estradiol should be stopped, and prednisolone also should be stopped. Dual trigger is always an advantage because with the agonist trigger, you get the FSH and LH surge both, which is becoming a very natural way. And with the HCG, you increase the luteal function, but many times you do a frozen transfer, then it's not an advantage. But in poor responders and hypo-responders, if the endometrium is good, your progesterone level has been maintained, and less than 14 oocytes have been retrieved, definitely plan for a fresh cycle, a fresh transfer on day 3 or day 5. There is nothing like that all freeze and only frozen blastocyst gives an outcome. It is not there. You have to select. Some patients at 41, 42, we do even day 2 transfers in the first cycle. Like today, I had a patient married for 7 months. She's just 42, tried for 3 months. She wanted to go for IVF. very low AMH. We retrieved 3 eggs. A grade, beautiful embryo, almost starting to merge, and we did plain vanilla IVF in first transfer. So the patient duration of infertility, what is the cause of infertility, will also guide you to how to stimulate and decide the embryo transfer. Dual trigger is now a norm. Double trigger very rarely, because I also had a bad experience when I gave Agonist 40 hours, HCG 34 hours before, and I take the patient for the egg retrieval and most of the eggs were ruptured. So you have to do it very guardedly. This, I have stopped doing it now. Choice of gonadotropin, definitely it matters. FSH has the follicles, the components which are seen are acid and the basic, and acid is mainly for the in vivo life is long and basic is short. So recombinant FSH, we have seen, gives more oocytes, more potent gonadotropin formulation is there, and higher biopotency of recombinant formulation. If we compare it with the other products, we see that the specific activity, that is the purity, is highest with the polytropic alpha, and number of oocytes, as I talked before, 1 to 2 also matters. You can see that with the REC FSH, always there was a oocyte collection of 1 to 3 more than the other products. So this is calibration. Now FSH alpha is available by bioassay and by mass. So what is better? They found out that the one with the mass is better compared to the calibration by bioassay. This was our own paper where we compared the Gnrh versus biosimilars, and we found out that even in young patients, the Gnrh group gave a better result. LH supplementation, very necessary. Until 10 mm, it is follicular group. Then the FSH receptors come up on the granulosa cell are there. LH receptors will come up on the granulosa cell. But the already existing theca cell LH receptor will respond to the LH in the follicular phase when you give. So there will be follicular recruitment. The action of LH in the late follicular phase is to maintain that growth and to give the competency to that follicle which is growing. No amount of FSH will give that. LH has to be given when we are seeing a stagnated growth. 1% of LH, 1.2% needs to be occupied, but still we need to give them. If the LH is low, that it has not crossed the threshold, okay, the follicular growth will be impaired, inadequate androgen synthesis and low follicular full oocyte maturation. If you cross that ceiling, then there will be downregulation, suppression of the granulosa cell proliferation, premature luteinization, and the follicular atresia will happen. And that's why sometimes in PCO patients, you know, towards the end, we start giving LH so that the small follicles which are growing becomes atretic, and the ones that are dominant will only grow. So you get less of the low small follicles growing up simultaneously, which would have otherwise grown when you give only FSH. Now, the threshold to be maintained, or the levels of this to be maintained, is 1.2 to 5. So any hypo, advanced stage, initial poor responder, follicular stagnation, suboptimal responder, any doubt of LH polymorphism, obese patients also may need LH supplementation, severely depressed, and PCOS, as I discussed the role. This LH supplementation will reduce the, is very helpful in reducing the miscarriage rate, improving the oocyte rate, improving the embryo quality, and increasing the fertilization rate by various mechanisms. It could be the ovarian paracrine activity, LH polymorphism, androgen secretory capacity, decreased number of functional LH receptors, and reduced LH bioactivity. FSH-dependent granulosa cell activities improve when REC LH is given, and there are a number of studies which have shown improved follicular maturation, and that is what it is important to get those cumulus cells and the maturity. And it is not only the maturity of the oocyte nucleus, it is also the maturity of the cytoplasm. And therefore, in advanced stage ovaries, it upregulates the growth factor, reduces the apoptosis, and enhances the expression of the anti-apoptotic proteins. LH supplementation, if we look at it, the important points they have said that in an antagonist protocol, this is a beautiful paper by Shah. He has explained why it is needed in antagonist protocol and which patients in antagonist protocol will need it. First 5 days when you stimulate, you think that the estradiol rises, but the LH drops. And ideally, after 5th day when the patient comes, the LH should drop, it should not increase. And that day when you give the antagonist, after 24 hours you measure the LH, it should recover by 50% or more. So today it's 1, tomorrow when I give the antagonist and after 24 hours I measure, it should be at least 0.8. Okay, I'm just giving a hypothetical number. But in the first 5 days, supposing that LH increases, you give first antagonist dose, the LH was 10, the next day LH is 2. There comes the LH deficiency. So it is the dynamic change of the magnitude of LH drop which is associated with low pregnancy weight and low oocyte quality. So some patient may hyper-respond to antagonist, and there is a risk of premature luteinization and premature rupture of follicle. But some patient may hyper-respond to that antagonist and the LH goes really, really down. And this was the study when they were identifying the Gnrh dosage, and they found that after the first antagonist injection, if there is a stark decrease in 24-hour LH, that means that patient needs LH supplementation. So magnitude of drop is very, very important. Well, there are two very significant players which govern the pituitary LH secretion. Which are those? One is the estradiol level and another is gonadotrophin surge attenuating factor. In a natural cycle, there is a rapid rise, but there is only one dominant follicle which is secreting it. And that is the cue to the pituitary LH surge. In most patients, comparable E2 levels, when we are stimulating them, already giving them injection, that 1000 picomole will reach within 5 days of stimulation. But still LH is decreased. You will say that now the surge should come. This is because there is this gonadotrophin surge attenuating factor which is taking care of it. Now in those patients which are surprisingly poor responders or who there is a hyporespondent plateauing, the excessive E2 or the diminished gonadotrophin surge attenuating factor is the culprit. Instead of a normal gonadotrophin surge attenuating factor that is very low. And if that is very low, it will not take care of it and it will allow this poor response in this patient. So this study hints that LH rising levels may reflect either over or diminished ovarian response. Now this was a study in where they have shown that LH supplementation, though it's a small, demonstrated a study significantly higher live birth in women who were given LH in antagonist cycle in which their intracycle LH levels were low, what I discussed. So this occurs in half of the antagonist cycle, and this is from Australia, and they showed that 50% where you give antagonist patients will have a reduced LH, drastically dynamic fall, and that's why they will not give a competent oocytes. You get 20 oocytes but mature 8, 7. So these are the patient hypothetically will definitely need, and therefore it is wise to supplement LH in these group of patients. More than 50% they identify. This was our own review study where we found out that LH in synchrony with the FSH stimulated hormone is necessary for normal growth and ovulation. Which LH to use? Recombinant LH, yes, because in the highly purified there is 95% HCG, and the HCG, if you see in vitro action, is 5 times more potent. It is more pro-apoptotic versus AHRI LH, which is more pro-growth and pro-differentiation. In the HCG administration, the progesterone levels rises and therefore the endometrial maturity also can be advanced. Therefore, REC LH is more important because it gives more angiogenesis, follicular recruitment, maturation, and competent oocytes. So this is that comparison. This is another SPART study which had shown that a fixed dose combination of REC FSH to LH2:1 is superior to REC FSH monotherapy in women with over ovarian reserve, and we ourselves have finished a study of Percoviris 100 patients. Along with this, in your patients of FSH, LH deficiency, healthy lifestyle, diet, exercise, less stress, acupuncture is always good. Regenerative medicine, we do a lot of PRP, BMDC, ovarian tissue activation, and with very good results, we are doing it, and now more concentrating on bone marrow derived. This study is under review. 37 patients with bone marrow derived, already 7 positive, and ovarian tissue activation, which I love to show. And we have now completed 15 patients for this, and the outcome is 2 already, 1 delivered and 1 conceived. The rest of them are trying, but these are really, really bad patients with just a streak ovary, where you cannot even identify the cortex and the medulla separately, where we are trying this protocol and doing this. This particular female, our first OTA baby of India, with a very low AMH. We did this in April 19, December 2023, good embryo transfer. 9th week, she had a miscarriage. After that, we told her to wait for 3 months. She was trying naturally. She conceived and delivered in May, the first OTA baby of India. To conclude, I would say it's very important that you identify and manage your patients in ART with LH and FSH deficiency. We don't want unpleasant surprises. It is very difficult to counsel a patient why she didn't get good quality mature eggs. Always use your previous patient if she had undergone any stimulation protocol. Poseidon criteria, think of it first, for everything you should analyze before you start the second, or if she has done an IVF cycle before. The hypo group will definitely need LH. You cannot stimulate them with oral ovulogens or only FSH. And the hypo group will always need an HCG trigger. Even if you see a lot of follicles, they will not respond to Agonist trigger. Please remember this. Then co-treatment with RLH has a definite impact even on implantation, clinical pregnancy, because with just the FSH, the progesterone rises and the endometrium advances, the LH takes care of it. The regenerative medicine can be a future for these patients. Further studies are required. Thanks from Zivia IVF, and I'm ready for any questions if there are.